Okay, I think we will begin. And for those of you who maybe this is the first time that you've been to Demystifying Medicine, I just want to say a few words about what the objective is and how we appreciate your suggestions. So the objective is pretty simple. It's to bring together in one format where possible a live patient who, as one student once put it, puts a human face on a disease to explain briefly what it's like to have whatever the disease is, and then an outstanding clinical investigator or physician scientist or someone who describes about the disease in terms that an intelligent layperson can understand. You don't have to have a lot of advanced preliminary coursework in order to take this. The intent of the course is to excite your interest and not to fill your head with a whole bunch of things that might, pertain to a medical school class or something like that. However, to help along the line, we have a website, and we post introductory material, some references, something to think about, and where possible, the PowerPoints that are going to be presented so that you have an opportunity to review and to read and think about the issues. So the material that's presented, we try to select each year about 18 sort of hot topics that are of enormous public health interest, basic research interests, and more importantly, where one element feeds off the other. Ergo, the symbolism, which I'm sure that everybody in this room recognizes as the greatest bridge in the world. That's the Brooklyn Bridge. And it connected Manhattan and Brooklyn in the late 19th century. Those gentlemen were what we are, explorers and adventurers walking along the catwalk of modern science and modern medicine. And of course, things were never the same on either side of the bridge after it was completed. And so that's also one of the big themes here. It's one thing to have a lot of money invested in studying a given problem, be it a fundamental one in biology or a more translational one in medicine. But that doesn't automatically take into account that people don't necessarily communicate with one another. And to do that, you have to have some understanding of what the other person is thinking and what they know. And most of you know a great deal about molecular biology and cell and immunobiology and so forth. And for many students, I have learned, there is very little exposure to what we call pathobiology or the disease. What's it like? What does it feel like? What does it look like? What's it all about when people use these words? So that's part of this. It's really an exercise in communication or bridge building. So, okay, we circulate a book, and if you would, just put your name, your institute, and check if you're a student, a fellow, a professor, a dignitary, or whatever, and an email address. And we use this as, we don't sell it to anybody, but it provides us with a clue as to the nature of the group that we are attracting. I would tell you that in past years, and I suspect it's true here, there are between 200 and 400 people who are online watching this live here at the NIH. And then about 4 days later, the material goes into the NIH video archive, where it's available around the world. And this kind of exercise, using some of the material that we've put together from truly the remarkable faculty that's here at NIH, it's used in now it's 17 different countries around the world. So we have a lot of international camaraderie out there. If you don't understand, or if you really have trouble following a speaker, don't hesitate, really don't hesitate to make it known because all the speakers are trying to enjoy the experience as well and to communicate. So please raise your hand or stand up or interrupt or say, I don't understand that. Don't do it too often. It kind of breaks the thread, but you get the message. And then there's time for questions and discussion and so forth. And that's what it's all about. And each week there's a different topic. Next week, well, you'll read about it. It's all on the website, and it's been in the Catalyst and so forth. And you'll see a list of topics throughout the year. So today's topic is, to my way of thinking, a fantastic thing from many perspectives, one of which is Neal Young, who is going to be the only speaker today, but will cover this wide range of bridging. And I'll tell you a little bit about him in a minute. But I think it's remarkable because it's one of these beautiful examples that this bridge soda business is going in multiple directions all at the same time. It's not simply that you do basic science and then suddenly it falls into place in some disease, nor is it that you know about a disease and somebody sequences a genome, and that solves the mechanism of those simplistic versions don't hold true. And this is a very good example. So if you could flip that first slide. No, that's Neal's. You got mine? I took the liberty of just putting two things on board that came to my mind, thinking about, because this topic of telomerase is one of the most explosive ones in medicine, spilling over into a huge range that you'll hear about of multiple diseases acquired and inherited. And in thinking about it, I realized that what's behind all this are basic questions. And that's the key to it. In whatever science you're doing, what's the question? What are you really trying to get at? And it should be an important question, something that really turns you on and is very important. And so the question, one of the questions asked throughout the up and through the 50s, 60s, even before was, how do cells age? How do tissues age? And why is it that some cells, transformed cells, they don't seem to age? And that's the question that people have thought about for a long time. And one of the people who thought about it in the 1970s was Leonard Hayflick, who, as it turns out, he and I played tennis together when I was on sabbatical there. And he used to tell me about this marvelous experiment he did where he just asked the question, what happens in cells age? So he took cells in culture and he kept subculturing them, and lo and behold, the normal cells all died after a certain number of passages. That was it. But the number of passages was pretty fixed. They died by a process that now we call apoptosis. And so he was interested in, how does that happen? And he began to speculate. This revolutionized thinking about aging, which at that point was way up in the air. Nobody really had a clue. And then I find one of the most interesting things, and I'm sure Neal is going to tell us much more of interest on this, that in the early 70s, a Russian, Lovnikov, initially working in Vladivostok, was interested in the question of, he knew that DNA polymerase can only act on a single strand. So how can that happen? How can a cell divide? How do you get the chromosomes to multiply, to divide? And he used a microscope. And he came up with the astounding notion that as cells aged, they lost the length of their chromosomes, particularly the ends. And I believe he coined the word. Is that right? Telomere? Well, at any rate, it means blunted end or short-ended, more or less. And so he proposed an idea that this was not only the mechanism of aging, but this was the explanation for Hayflick's observation, which turned out to be true. And he also knew that cells were replenishing this end of the chromosome. And I guess he didn't use the word telomerase, but he said there must be a system that keeps the length of the tip of the chromosome in balance. And he wrote extensively about it, and he kind of predicted telomerase. He had this hypothesis of aging and also a relationship to cancer, because this whole process was greatly disturbed in tumor cells. And one thing led to the other, and then we wind up in 1984 when Susan Greider, who was a graduate student, I believe, in Elizabeth Blackburn's laboratory, actually purified telomerase. And that started the ball rolling in the modern era, because you had something specific to work with. And that was done in tetrahymena. From hearing Dr. Blackburn talk about it, it was because they were interested in the basic process that was involved. I don't think, but you will know better, whether they really had any thoughts about things like bone marrow failure and everything else being involved. This was a so-called basic process that was being there. But there was a lot of communication going on, which we will hear about. And the Nobel Prize in 2009 was shared with Dr. Shostak at Harvard, all dealing with the structure and the function of telomere. And I have one other slide, because these are other thoughts that went through my head, that now this is a telomeric explosion. And we'll hear how it's exploding. How do they work? What's the role of telomeres in aging, cancer, now inflammation, fibrosis, particularly of lung and liver? The role in stem cell biology. If there are mutations that lead to fascinating phenotypes, inheritable diseases. It's like a Pandora's box. And through it all, the notion that, my God, maybe there are some targets in here, particularly with respect to cancer chemotherapy. So this is one of the most explosive, exciting areas in modern medicine. So Neal Young is a physician who graduated from Johns Hopkins. Came to NIH. Well, he did a residency in Boston, came to NIH, where he learned protein chemistry with Chris Anfinson, who won the Nobel Prize for that year. And then he did a more clinical fellowship in hematology in St. Louis, came back to NIH in the Heart and Lung Institute, and was a fellow now learning molecular biology. Now, what's happened is Neal has had this long interest in bone marrow failure. That's when you don't make enough red cells, or maybe it's platelets, or maybe it's white cells, or maybe it's all of them. And these are very common situations in medicine, and sometimes, frequently, they're lethal. And so the center here at NIH has become maybe the major one in the world for people referring because of what's called bone marrow failure. So now you combine a physician who knows about the disease and the patients, who collaborates, works with, and understands protein chemistry and molecular biology, and a Nobel Prize given in telomerase, and exciting things are bound to happen. And that's what we're going to hear about. So, Neal, we're very delighted that you agreed to speak. Oh,
so, thank you, Erwin. And before I actually get started with the formal lecture, patient is very kindly consented to come. So maybe I can ask Ms. Helms-Gouda to come over and we can do an interview. This actually mimics, for those of you who actually have done any clinical work, I'm looking at Jerry, it mimics the situation in the clinic in that the chart is lost. So I'm really, I'm going to really depend on her to give us the history of her own illness. And I'll start by asking you why you came to NIH in the first place.
I came to NIH because I was told I had aplastic anemia. I have a known H-ATG mutation. I inherited it from my father's side of the family. And I was interested, I met Dr. Townsley at a plastic anemia conference, and I was interested in some research protocols, particularly the Danzol. So I came here to get evaluated. At the same time, I also am participating in Dr. Alter's and Dr. Savage's study looking at cancer in bone marrow failure patients.
And the aplastic anemia was based on low blood counts, but not terribly low blood counts?
Yeah, not terribly low blood counts. I mean, my white blood count went down to 1.8, and I'm borderline anemic. My platelets have been about 100, 118. But I also have a T cell and a B cell immune deficiency on top of everything.
And just a bit about your family history. Your father had pulmonary fibrosis. Anyone else in the family?
Yes, actually we have had 4 people die of pulmonary fibrosis. My uncle died of leukemia. We have at least 3 other family members that died probably in the 50s and 60s of COPD, but if it was probably diagnosed today, it might be pulmonary fibrosis. So we actually, I'm a nurse, I'm a retired Air Force nurse. I suspected that it was hereditary, so I found a researcher at University of Texas, Dr. Christine Garcia, and she was looking for the gene for pulmonary fibrosis. So my father, at the time when he was alive, him and his cousins, they sent blood samples, and we didn't hear anything about it. So after my father died, they called the children back and sent some of us cousins down, and we were tested. 2 of us came away from the test having abnormal CAT scans. My cousin died 2 years from the study, and he was only 55. I'm 50, but at the time I was 46.
And are you symptomatic now at all?
I like to think I'm not symptomatic, but I do have some mild problems. Probably my gastric problems is my #1 problem. I've had a lot of problems with swallowing, eating. I've been diagnosed with gastroparesis, irritable bowel syndrome, a hiatal hernia. I've tried numerous diets. My newest diet is a FODMAP diet. So, and I'm on medicines for gastric reflux.
And no other medicines besides that?
I have Raynaud's, so I take medicine for that.
And no liver problems in the family?
Oh, yes. We have one cousin that died of liver cancer in his 40s. Another cousin died of liver cirrhosis in his 50s. I have another cousin on a transplant list, and he's around 60.
Okay, those are liver problems.
Yeah.
All right, so I think so that I can actually do my didactic stuff. I'll stop your story at this point.
Okay.
And thank you so
Thank
much
you.
for being here. It's not so easy to reveal all these details about your own history. So I feel as if you've actually gotten all the interesting information between Erwin's historical introduction and brief summary of the problems and listening to this very eloquent patient describe a really typical family with telomeropathies, but I'm obligated to give you an hour of slides anyway, so that's what I'll proceed to do. This is actually a 2-part talk. The first part really deals with aplastic anemia, which has been an historic interest of my group and of NIH for now coming on 30 years. And that in and of itself has been informed by the science, as Erwin described to you, and it's a very nice story of learning from patients about the pathophysiology, the mechanisms of their diseases, and then, which is really possible at NIH, being able to go back to the clinic and apply that in research protocols. And this is one of the big success stories in hematology, because we've been able to take a disease that was really uniformly and rapidly fatal and make it into one that we actually can cure or ameliorate disease in the great majority of patients. So that's the first part. But that will then follow into the role of telomere shortening, both as part of the pathophysiology of aplastic anemia, as an explanation for one of its major complications, a still very difficult one to treat, and also the genetic insights that have been provided by families, such as the one that you've just heard about. So the first slide is historic. I study bone marrow, and that's where progenitors are located, so you like to have a good progenitor for your own work, and the progenitor that we have in aplastic anemia is Paul Ehrlich, also won the Nobel Prize, although not for aplastic anemia. When he was a very young man, he was a docent in pathology at Charité Hospital in Berlin, and he's credited with publishing the first case report of a patient with aplastic anemia. A very unfortunate young woman who was pregnant, came in with a catastrophic illness, was dead within just a few days, probably mainly of anemia, but she undoubtedly was also bleeding from the description and probably infected as well. And in this very brief case report, which would not pass muster in modern times, the real finding was the femur. And when this young pathologist opened the femur of this patient, who had very profound anemia. That was the easy thing to measure in the 19th century. We weren't doing sophisticated things like white cells and platelet counts. She was anemic, but she didn't have the typical appearance of pernicious anemia, the anemia of B12, which we don't even think about anymore, but killed a lot of people. That was why it was called pernicious. And the typical bone marrow pernicious anemia is very rich, very full of progenitor and precursor cells that they just aren't forming red cells normally. Instead, he saw fat. He saw just a yellow appearance and commented that this appeared to be different from pernicious anemia. It wasn't any wiser than that. But other actually very smart people around that time did pick up an interest in this disease, almost always through autopsies of young people, did make, even before we understood how the bone marrow worked, did make the inference that these patients really had a failure of hematopoiesis, a failure of blood cell production. So it's a disease in which that pathophysiology has been suspected for 130, 140 years. So this is a patient who has much worse blood counts than you've just heard from our live patient, who has really very mild pancytopenia, which has been stable and it may never, in fact, bother her in any major way. This is a patient who has very low white cells, very low platelets, and is anemic. And physicians can see this pretty obviously. This patient is pale, and you can see that she's bleeding in her mouth, and she has these little red dots that are called petechiae, which occur when the platelet count is down on the order of 10 or 20,000. Lisa's platelet count is in the order of 100,000. She could go through major surgery without any problems with that blood count. And now this is something like the bone marrow that perhaps Ehrlich saw. The normal bone marrow shown at the bottom. This is a bone marrow biopsy. It's obtained from the hip with essentially a sophisticated medical version of an apple corer. It's a very clever device that allows you to go in and essentially cut out a core of bone marrow tissue, remove that core, and send it to the pathology laboratory. And if you look at a normal bone marrow that's shown below, it's full of those blue cells that are going to make red cells, white cells, and platelets. And the patient with aplastic anemia, this is one of the easiest diagnoses to make in the pathology lab. Even I can make it. There just are no cells. There's just fat that's replaced the normal bone marrow. Now, this is a 21st version of the appearance of a bone marrow. This is from our confocal microscopy court. It was on the cover of a journal, mainly because I know the editor very well. But this is a very nice picture of what in 3D, of what the bone marrow of a patient with severe aplastic anemia looks like. And the green are the fat cells. So these cells have expanded for reasons that we don't know, and they've replaced the blue cells. The only blue cells that we see are those that are coating the bone. The blue cells that would be red cell, white cell, and platelet precursors are missing. And CD34 stains progenitors, but they're absent, and the CD34 is staining only the blood vessels. It also binds to the antibody binds to the endothelium. So you have this very beautiful three-dimensional vision of the aplastic bone marrow. Now, as Erwin and I have mentioned, this is a really bad disease historically, and when I was in training back in the 70s, everyone we saw with aplastic anemia of the severe variety that was defined by blood counts died. And this was really a terrible experience because these were young patients. And most diseases affect older people. That's just an unfortunate fact of life as we get older. So diseases that affect young people are particularly disturbing. And we would see patients who were in their late teens or 20s, the age of a lot of the postdoctoral fellows were in this room, who were usually previously just fine and would come in with the sort of appearance I just showed you. And in those days, the professors of hematology really had nothing to offer the patients. They would get a few transfusions, but they really were sent home to die. And the speculation all had to do with why the patient caused this, what the patient did that was harmful. It was really sort of unfortunate. But you can see from these mortality statistics that when patients have low blood counts, almost all of them had died by the first year after diagnosis. And as I told you, these were mainly young patients. This is from our own group, and you see that the peak of this curve is down in the 20s or 30s. So you can see this yourself. You don't need a pointer. Now this is a disease that's interesting in a lot of ways, not all of them explicable. This is a photograph of a hospital in the north of Vietnam that I took some years ago. We had a teaching program and research that we also did in Southeast Asia. And when you go to Asia, aplastic anemia is much more common in hematology clinics than it is in the West, still for unknown reasons. I spent a decade doing a major epidemiologic study in Thailand, and the rates are 2 to 3 times higher, which for a disease that doesn't have an obvious infectious etiology or a genetic origin is really strange. We don't have a good explanation for why this disease is more prevalent, certainly in East Asia and perhaps in other developing countries as well. And there's a very important historic relationship. This is the one that, in fact, the professors of hematology in mid-20th century harped on, that related aplastic anemia to exposures. These were mainly benzene exposure, but I'm showing you on the left here is a newspaper article from a newspaper in New Jersey actually describing benzol poisoning occurring in leather workers. And there was a terrific crusader against benzene exposure in industry. He was the coroner in Essex County, a pathologist, who recognized that benzene could cause all sorts of bad things, including leukemia, but also bone marrow failure. The stories that we're told about Harrison Martland is that he would just hold up the slides. He could make the diagnosis of aplastic anemia without actually going to the microscope because it was so visibly different from the normal bone marrow, and then he would just advise the physicians to send the patient home as there was nothing to be done for them. If any of you have read the Philip Roth book, American Pastoral, it's set in Newark, and there are these very, actually for me, vivid descriptions of these immigrants from Italy and Greece, who the south of Europe, who would come to Newark, where there was very readily available energy due to the local rivers, and work in the glove factories, and they were of course exposed to benzene, which is an excellent softener for leather. This is still a big problem in places like China, for example, where there are actually epidemics of benzene poisoning that occur in the unregulated leather industry, unregulated benzene industry there. This is not a problem in the West anymore. There are really rare patients who have exposure to chemicals like benzene, and rather the big associations with medical drugs. That's much less common than what was thought to be the association between benzene and bone marrow failure. But occasionally a patient will take a drug for some indication and aplastic anemia results, or seems to result, follows on that drug exposure. And of course it's a catastrophe for the patient, catastrophe for the treating physician, because he thought he was just treating thyroid disease, but now he's got a patient with a fatal blood disease on his hands. And it's also a disaster for the pharmaceutical industry. And what I've shown you is just from the New York Times business page, and it's the fate of the stock. Actually, the employment in Carter Wallace followed the same track, when just a couple of dozen cases of aplastic anemia were linked to a new anti-epileptic drug called felbamate back in the 1990s. So this is a disaster in drug development. You know, millions of dollars can be devoted to developing a drug, and then it's only when it gets out in the market that this is discovered. So I made the sort of snarky comment that the older physicians of the last epoch really emphasized the etiology, and that we had endless discussions. And I remember, I mean, I'm a smart aleck also with I always get a better history than my fellows, but that's because I go into the room after the fellows have asked the questions 3 times, and I go in and I ask the 4th time, and now the patient remembers that they actually had a relative or had this particular symptom. But that was really the emphasis back in the 50s, 60s, and 70s. We had long discussions, and famous people would say, well, you know, you had benzene exposure 20 years ago when you did this or that, and that's the reason you got aplastic anemia. And then, as I said, that was the end of the story for the patient. So aplastic anemia was seen very separate from other blood diseases, seen separate from other diseases, just sort of an oddity in and of its own, and with all these potential causes. By the way, as when I was young person trying to address this disease, it really seemed impossible to study it for 2 obvious reasons that I've shown you. One is there were no cells to actually study. The bone marrow's gone. So what are you actually going to examine? And the second is that this really suggested heterogeneity that meant it would be impossible to ever get a nice cohort of patients who all looked exactly the same, had the same sort of histories that we could study. So it really seemed an impossible task. Well, this is the modern, not necessarily the final version of what we think is going on with bone marrow failure. You'll see that I'm going to modify this when we talk about the telomeropathies. But we now have a much simpler version of this disease that really ignores this inciting or putative inciting etiology. You know, is it this or is it that? Because we think that from our experience in the clinic, that most patients with aplastic anemia, whatever triggered the disease in the first place, are suffering an immune pathophysiology, that the immune system has turned on their bone marrow and destroyed it. And that whatever triggers that immunity or autoimmunity is probably similar in many immune-mediated diseases. And you know people who have multiple sclerosis or inflammatory bowel disease or uveitis who, again, may usually be perfectly well until the disease strikes, sometimes seems to follow on an infection, they had a virus, and then a month later or 2 months later, one of their organs is affected. And we know that the variability in those diseases is enormous. You have people with a single episode of bloody diarrhea every 3 or 4 years. We call that inflammatory bowel disease. You have people who present and have to go to surgery immediately. They also have inflammatory bowel disease. So the spectrum of the damage to the target organ is very broad, but we think the pathophysiology is the same in all of these. So we can treat, once the patient's marrow has failed and they present with low blood counts, we can address that in 2 major ways. One is we can transplant them when they're young and they have a donor that's a good match. You can replace the bone marrow and the immune system at the same time the patient's cured. And except for the complications of transplant, that's an excellent way to address the disease. But most patients don't have a donor, and bone marrow transplant is difficult to do in older people, meaning people in adult life past the age of 40, let's say. And in those patients, we can get comparable results by, in fact, treating the immune system. By reducing the immune attack on the bone marrow, we can actually allow the bone marrow to recover. But we do have this problem, which I'm going to come to later in the talk when I talk about telomeres, which is that a subset of patients with aplastic anemia do go on and have a malignant course. And they'll have myelodysplastic syndrome or acute leukemia develop years after they present with aplastic anemia. And we still don't entirely understand that, but telomeres offer us a pretty good explanation. So now we see aplastic anemia much more related to other blood diseases and related to other human diseases. So the immune part is really, as I suggested, parallel to what goes on in a lot of other single organ T-cell mediated immune attack like multiple sclerosis, diabetes, and so on. We also see the disease related to leukemia, as I've mentioned, and we see the disease, as I'll tell you, related to inherited syndromes, genetic syndromes that have discrete mutations that affect the ability of the bone marrow to repair. And that's the addition that I'm going to describe here. You see these mutations that I've pointed out in this revised version of this slide. So let's talk about the immune pathophysiology very briefly, just to give you some of the drama of treating patients with severe aplastic anemia that we now experience fairly routinely, but was a big deal back in the 1980s. So this is a young patient who came to us with a very stereotypical form of aplastic anemia. He's a 16-year-old boy from Colorado who had had an episode of hepatitis about 3 months earlier. And it's a very peculiar, very particular type of hepatitis, non-A, non-B, non-C, very high transaminases, very high bilirubin, but he got better. Unfortunately, 2 months after or 3 months after that episode of hepatitis, his bone marrow disappeared. It's an extremely severe form of bone marrow failure, almost always rapidly fatal. And he came to NIH with no white cells, dependent on red cell and platelet transfusions. This is just the chart showing his blood counts. And he received a very brief course of treatment with antibodies directed against human thymus cells, anti-thymocyte globulin, and 6 months of cyclosporin, an immunosuppressive drug that we use in all sorts of circumstances now. And you can see just by following the white lines that all of his blood counts improved over the course of several months. They actually came back to normal. He's been fine. He's led a normal life in the intervening 20 or so years since I initially saw him. So this is a very dramatic occurrence, and it was really this clinical observation that drove many of the laboratory studies that we and others have done to show that the immune system, is responsible for this attack. And I'm only going to show you a couple of summary slides. Is that better? Even higher? Okay. So this is really meant for clinicians. It's not something that people in a research lab need to know in detail. But I've just shown you a summary that was recently prepared for one of the clinical journals of the results in clinical protocols, clinical trials of the purposeful application of ATG and cyclosporin. And the results are very consistent, somewhere between 60 and 80% of patients who get a single round of this really not very difficult immunosuppressive therapy will recover their blood counts and be transfusion independent. NIH, by the way, does the largest studies, even as a single center, so we probably actually are the largest bone marrow failure clinic in the world at this point. This is just an example of the sort of studies that are done and the sort of illumination that can come from doing clinical research. We did a study that we completed about 2 years ago comparing a very dull study comparing two different types of ATGs, one made in a horse and one made in a rabbit. So these animals are both being immunized with human thymocytes, making antibodies to these T cells, and we then get from the pharmaceutical companies preparations of horse or rabbit ATG. And we actually did this study with the hypothesis that the rabbit ATG, which had just been introduced into the American market and was much more potent, would be better, give us higher response rates than 65 or 70%. This is one of the studies that I've done recently that's convinced me that clinical research is really hard to do, and it's very hard to predict outcomes because the result we got is exactly the opposite of what we predicated. Fortunately, we had powered our study statistically to detect a large difference, and that large difference appeared. It just appeared in the opposite direction from what we thought would occur. So horse ATG, which we've used for years and years and years, turned out to be much better than this new product on the market, the rabbit ATG, with a really quite different, markedly different, almost twofold different in the response rate. And doing this study was very difficult. It's really, there are many stories that I could tell offline about how hard it is to do this sort of randomized controlled trial, especially when you know what the drugs are, even when you know the patients. But unfortunately in Europe and South America, physicians have been using the new rabbit ATG. It was being marketed as being more potent. Horse ATG was actually withdrawn from the market. Only after the study came out did papers then begin to appear from these other venues saying, geez, we've been having terrible results with rabbit ATG, but we just assumed it was bad luck. And in fact, it wasn't bad luck, so it's really changed practice. The reason for that, by the way, which I won't go into, has to do with discrete immunological effects that horse and rabbit ATG do not share, that they both can reduce T cell numbers, but horse ATG spares the regulatory T cells. And that's the most marked difference in these patients after they're treated, that the regulatory T cell compartment is intact in the horse ATG patients, but it's eliminated in the rabbit ATG patients. So the good news is that with this disease, which I showed you had an 80 or 90% mortality, in those majority of patients who respond to immunosuppressive therapy, these are the sort of survival curves that we now see. And you can see that virtually everyone in the modern era who responds to a single round of ATG is surviving out at 8 or 10 years. The death rate has really been reduced dramatically, really markedly. Now, I'm not going to, there are hundreds, maybe thousands of papers that have been published on the immune mechanism, but there's a simple and elegant way of describing what we think is going on in the bone marrow patients with aplastic anemia. It's in a mouse model. These are, again, these confocal images that are so lovely to look at. But you can create bone marrow failure very easily in the mouse. And this is not a discovery of ours. This was actually recognized back in the 1940s and 50s as runt disease, the origins of the mouse models for graft versus host disease. So if you take cells that contain lymphocytes from one mouse strain and you put them into another mouse strain where there's a difference in the H2 major histocompatibility antigens, the incoming lymphocytes from that donor mouse will destroy the bone marrow of the recipient. And if you engineer your strains correctly, that's the only organ that's affected. And you can see that in these images. So here's the bone marrow in a normal mouse. It's quite cellular. You see all that blue are the hematopoietic cells, very little fat. That's about a week after lymph node cells have been injected into this animal. This is 10 days later, and now you can appreciate that fat is replacing the blue cells. And shown here also in green are the invading cytotoxic lymphocytes, which are destroying that bone marrow. And very small numbers of lymphocytes are capable of completely eradicating, and very specifically eradicating the bone marrow. I mentioned that we worry about drugs, we worry about benzene. You can't get such specific and marked effects with low concentrations of any drug. And you've got to use really heavy cytotoxic chemotherapy to get this sort of bone marrow appearance, and of course you affect a lot of other organs. So the T cell, the immune system is much more specific at targeting and killing any organ than we can design with a drug. So this is just a summary of how well we've done with immunological therapy, but we do have failures, and that's the second part of what I want to say about aplastic anemia, because the failures are upsetting. Obviously, you take patients, you want to get everybody better, but you've got those 20% of patients or so who will not respond to 1 or even 2 rounds of immunosuppression. And we've predicated that the reason that they don't respond, as I alluded to with inflammatory bowel disease or with other autoimmune diseases, is it's the amount of target organ damage. And that if you've got 10% of your stem cells left you're going to do better than if you have 0.1% of your stem cells left. And that you can shift the probability of recovery if you could have some way of increasing the number of stem cells. That's been a dream for a long time, but again, more or less accidentally, we may have stumbled on a way to actually do that. So we know that the stem cell compartment with surrogate assays of hematopoiesis is reduced in everybody who has aplastic anemia. And you can just look here at, I think the easiest thing is just to look at the blood values. This is the assay is not important for you, but this is the number of the pseudo stem cells that we can detect in the blood of normal people. This is obviously a logarithmic scale. This is patients with aplastic anemia. This is the bone marrow, where I've told you there are hardly any cells, and this is on a per mononuclear cell basis. And this means that the reduction in stem cell numbers on the order of 1 or 2% remaining stem cells. So the marrow is a great organ. It can compensate for blood loss. It can compensate for low blood counts. And it doesn't really allow clinical presentation until there's such an enormous reduction in the stem cells that the patient's essentially exhausted their stem cell reserve. So we also started a study with exactly the wrong reasons, which was that we wanted to prevent our colleagues in private practice from using an expensive drug needlessly. There's a drug on the market that can improve platelet production in a very specific circumstance, ITP, mainly a childhood disease. It's on the market, it's expensive, it's a pill, it has very little toxicity, and we know that growth factors don't work very well in patients with aplastic anemia. Their problems, their stem cells. And if you give growth factors like erythropoietin, Lance Armstrong's favorite drug, or granulocyte colony stimulating factor that can increase white cells, they don't work in patients with aplastic anemia because they're already making tons of EPO and tons of all the factors that they need. So Cindy Dunbar and our group had the bright idea of doing a good NIH study that would be purposely negative, that we would do a study showing that this drug called ELTROMBOPAG did not work in patients with aplastic anemia, so that we would avoid the loss of revenue and loss of patient time and so on. So ELTROMBOPAG is a very cool drug. It's a synthetic mimetic. It's a chemical that imitates the behavior of a hormone. That hormone is thrombopoietin. It's a factor that's produced by the body to stimulate mainly platelet production. Thrombopoietin, thrombocytes are another word for platelets, and that's why it's effective in ITP. It's a synthetic mimetic because you can't actually use the whole hormone. There are problems when you actually inject thrombopoietin into a person. It doesn't work like erythropoietin. It can cause really serious complications. So the drug's on the market. We can get it from the company, and we decide to treat patients who are in that category of refractory. They have not responded to immunosuppression. Their blood counts are low. We're keeping them alive with transfusions. They're in clinic for months or years after we've failed at our treatment, and we'll treat a couple of dozen of them and show that we have no change in blood count. So, and why do we expect that? Because we know patients make tons of thrombopoietin. We've studied that for 20 or 30 years. It's an important paper that aplastic anemia has got the highest TPO levels that you can measure in anybody. So this is the study. You can see that it was successful because there's a little New England Journal logo at the top, but it was successful not because it was negative, but because it was surprisingly positive. So amazingly, almost half of these patients that we treated, who were just sitting there in clinic doing nothing, responded, and their responses were very striking. Not only was the response rate relatively high, almost 50%, but the responses were very robust. They also occurred in multiple lineages, meaning that it wasn't just the platelets that improved. All the blood counts got better. And if all the blood counts are getting better, that's very suggestive that we're actually impacting the stem cell. Not all three lineages, but actually the hematopoietic stem cell. That's almost certainly what's going on. So you see that the majority of the improvements occurred in hemoglobin, neutrophils, and platelets. And this is the robustness of the responses. So these are platelet counts, 40,000's a big difference in platelets. And you see that some of these patients have platelet counts that rise right into the normal range. Hemoglobin's even more impressive. 4 grams, that's a huge difference. We only have 12 to 15 grams of hemoglobin in our blood. So 4 grams is a huge amount of increase to see in these patients. In fact, it allows you to start removing blood from them so you can get rid of the excess iron that you've given them with transfusions. I won't show you, but the white cells also went up. And the third big difference is that in contrast to immunotherapy, where you can often get better blood counts, but the bone marrows kind of still look empty, the bone marrow is often filled up in these patients with cells. They filled up with the precursor cells for the red cells, white cells, and platelets. They look normal 6 months or a year after you started. So this really does look like it's a treatment, probably the first treatment that we actually have to increase stem cells in humans. So we've now shifted this curve, we hope, in a favorable direction. And the current study that we're doing, which I'll show you just a few results of, is combining in patients as they come to treatment at first, immunosuppressive therapy with L-Trombopag. Very easy to do that. And these are the sort of results we've gotten just in the first 13 patients or so that we've seen. I saw actually 4 of these patients this morning at the 6-month landmark. So almost everybody responds, and the responses occur very quickly. So at 3 months, you're already seeing patients who are in complete remission or complete responses or partial responses. And these are, again, historically, these are very dramatic responses. If you just look at the bottom of the reticulocytes, in these responding patients, the reticulocytes are in the normal range within just a few months. So they come off transfusions very quickly. And we can even measure CD34 cells. I told you that's the antigen that marks the compartment that has stem and progenitor cells, and those numbers are going up by 10 or 20-fold even in a 3 or 6 month period. So it's consistent with this being a direct stem cell effect. Okay, that's all the good news. Now this is bad news. So this is the patient I showed you at the beginning, who was one of our successes. She responded well to ATG, but a decade or so after she was treated with immunosuppressive therapy, she came back bleeding. She now has leukemia, that's what the bone marrow shows, and she's got chromosome abnormalities. And this is what's called clonal evolution, an evolution in which a clone of malignant cells has come from this empty bone marrow. And this occurs in about 15% of patients. This is just a Kaplan-Meier plot showing the frequency in a very large number of patients that we've treated. So it doesn't occur in everybody, that's good, but when it does occur, it's really hard to treat because even giving chemotherapy is virtually impossible since the patient doesn't have a normal bone marrow to start with, so they really need to get transplanted. So this relationship between leukemia and aplastic anemia has been recognized since the mid-20th century, a very famous editorial by a great hematologist named William Damashek, and I and others have followed on speculating on why we have this problem of clonality in aplastic anemia. And the problem of clonality turns out to be solved by this very basic biology that Irwin referred you to earlier. And in fact, it goes back even before McClintock and before Hayflick and Olovnikov, as I'm going to show you in a moment. And it really is a problem not just of the DNA, but a problem of chromosomes themselves. So Barbara McClintock, working all by her lonely self and publishing only in the journal, which would have a very low impact factor today, the Cold Spring Harbor Quarterly, working on maize, and Hermann Mueller, who was interested in different cell systems. He worked all over the place. He was in Europe and the United States. Both of them, before DNA had been discovered, recognized that there was something funny about normal chromosomes, and that if you fragmented chromosomes, as for example when Mueller radiated cells and created chromosome fragments, they were very unstable. The cells would not tolerate them and the cells would die. And it was actually Mueller who termed the ends of the normal chromosomes telomeres. I actually prefer McClintock's much more down-to-earth phrase, which is the natural ends of chromosomes. That's what she called them, and that she recognized that these were just different from the bad fragments that occurred with damage. And here's the original paper of Olovnikov, who was really working theoretically. Once DNA was discovered, he recognized that there was a problem with the mechanism by which DNA replicated. The semi-conservative nature of DNA replication, as Irwin said, means that the DNA polymerase is sitting on one strand, and you've got that Okazaki fragment that's created for the replication of the other strand. And Olovnikov realized that when that DNA polymerase machine got to the end of the leading strand, you couldn't form a fragment underneath it. And there would be what he called it the theory of marginotomy, that there would be a loss of genetic information with every mitosis just as a result of replication. That was done entirely on theoretical grounds. If you read his autobiography, he says this insight came to him in the Moscow metro. This is a picture I took of the subway. There you can recognize the fancy chandeliers. It tells you you're not in our metro system. And supposedly Olovnikov was sitting on the platform and he realized that there was this gap between the end of the train and the door. That's where the DNA polymerase sat. And I think, even when you look at his diagrams, which are, I think, still quite informative, it looks a little bit like trains on a track when he actually drew these, probably drew them himself.
for the English version of his paper that appeared 2 years later, which is unfortunate because actually it was Watson who got the credit for this. He was doing experiments with phage bacteria, and I'll read what you can read, which is that he recognized there was a problem with DNA replication based on experimental data. He said, while 5' 3' oriented growth should proceed smoothly to the end of its template, I see no simple way for 3', 5' growth to reach the 3' end of its template. Okay, that's the intrinsic problem. That's the loss. And as you heard, Blackburn and Grider received the Nobel Prize for recognizing for discovering the biochemical, the molecular nature of the end of the chromosome and also the repair process. So what is the telomere? It's actually a very easy structure to define. The telomere is the end of the chromosome, and it's composed of hundreds to even thousands of repeated nucleotide sequences, a hexanucleotide that's preserved through many, many species, and very primitive species as well. So that's the telomere with associated proteins. This is called the Shelterin complex of proteins, and this is what constitutes the natural end of the chromosome. It's what prevents DNA excision enzymes or other DNA damage responses being activated by seeing bare DNA ends, or mistaking the chromosome, for example, for a DNA virus or for a DNA or chromosome fragment. So that protects the chromosome as a complex. Of course, it also is pretty dispensable. There's no genetic information contained in these repeated hexanucleotides. So if you lose them, as we inevitably do, there's no great deal until you get down to a very critically short telomere. So it's kind of junk material that it's the end. But the third aspect of this telomere structure is that these hexanucleotides provide a template for an active process of repair, of synthesis of telomere material after every replication. That's the telomerase complex. And it's a reverse transcriptase with associated proteins, just like an HIV or a retroviral reverse transcriptase. It acts from an RNA template to make DNA of this hexanucleotide over and over and over again. So the terminology here requires very careful articulation. There's a gene called TERT, T-E-R-T, that makes the enzyme component, and there's a gene called TERC, T-E-R-C, that makes the RNA. It doesn't make a protein, it actually just makes this RNA, which you can appreciate with its hairpin loops. So this is the template for the telomerase. There are also other genes that make proteins that contribute to this complex molecular machinery. But as you heard from our patient, it's a mutation in TERT or in TERC, which are the ones that we recognize most commonly now in a clinic of adult hematology patients. So what are the consequences of getting a really short telomere? Well, as you heard, that's the explanation for the Hayflick phenomenon. So when a cell has one chromosome with critical telomere shortening in one chromosome, it generally will go to sleep or destroy itself, undergo apoptosis. That's the usual default pathway. That's okay, that's benign. That means the cell is just out of the picture. It makes it hard for us to grow fibroblasts in cell culture, but Darwin, evolution wasn't designed to make laboratory experiments easy. If the DNA damage response is not intact, though, if P53, for example, is dysregulated so that the cell doesn't recognize that there's DNA damage, then there's problems. And what occurs in cell culture, what occurs in animal models, and what we think occurs in some patients as well, is that the chromosomes, not the genes, but the chromosomes begin to rearrange. They fragment, there's end-to-end fusion, they get pulled across that telophase plate, and there's aneuploidy and ultimately malignancy. That's well established in hundreds of in vitro experiments. Okay, so let's talk about what are the consequences of telomere mutations in patients. So this is our description, again in the New England Journal, of the first mutations that occurred in the enzymatic component, which is the most important because it's the regulatory component. This is what goes up or down in cells that are trying to repair their telomeres or that are actively replicating in an embryo, for example, in bone marrow, in some lymphocytes, and so on, not in fibroblasts. So these mutations that occurred in the telomerase gene, in TERT, were really a surprise to us because they occurred in people who looked like they had just run-of-the-mill acquired aplastic anemia. They'd come in, some of them have been treated with immunological therapy, they can respond to immunosuppressive therapy, but they have mutations in this gene, and the mutations are visible even in a simple clinical assay. We can measure telomeres now in the laboratory, and what you see in red are the telomere lengths in these first group of patients, and yellow is showing you the normal range. There is a range. Obviously, we don't all have exactly the same telomeres, but you see they're very, very short, easily discriminated from the normal. I'll just point out that if you do look at the pattern of normal telomere attrition, it does occur, and as I said, as we speak, our telomeres are all getting shorter, but most of that is occurring in our youth, as we're making our cells bigger before the age of 20. That's when most telomere shortening is occurring, and then in much in old age. It's really fairly stable through most of middle life. So there are a variety of presentations of telomere disease, and I'll just show some of them. You don't have to go off into the clinic and make these diagnoses, but it actually turns out that this is not particularly rare. Aplastic anemia is rare, but the telomere diseases are not rare, partly because, as you heard from our patient, the blood may not be severely affected. Her blood counts are actually in pretty good shape, and if it weren't for your family history of pulmonary fibrosis and a very astute physician, those blood counts would be ignored. We'll just follow them, we'll just watch them. So it's in these the sort of the outer ranges of severity that really those are patients who have just never been recognized and never been studied. So let me give you a couple of the examples. So this is one very dramatic case. This is actually late presentation of the childhood syndrome, which is very characteristic because of the nail findings. The nails look like they've been chewed to bits. Kids come present with this in the first year or two of life. This is called dyskeratosis congenita. They have bone marrow failure, and they're almost all dead by the age of 10. So they have very severe onset, early onset aplastic anemia with these associated skin and nail findings. But this is a guy who was in the Army. He was actually airlifted out of Afghanistan. He had normal blood counts, but he had tongue cancer. And that's extremely prevalent in patients with dyskeratosis congenita. And a very really excellent Army hematologist made the diagnosis of dyskeratosis congenita in this patient just by looking at the nails. He got a single round of chemotherapy for his metastatic lung cancer. That's what the CT scan is showing you. And his blood counts completely disappeared. So he had an underlying bone marrow problem that didn't become manifest until he was challenged with chemotherapy. And we identified a gene in the dyskeratosis protein, which is a protein that stabilizes the telomerase complex and is really critical. This is the other end of the spectrum. So this is a patient we saw in clinic a few months ago who's really not very ill at all. Again, the more typical presentation. He's had very mild low platelet counts for about a decade, not particularly progressive. He's got big red cells, which turns out to be a great clinical tip. He did not have a family history, and about half of our patients will not have the sort of vivid family history that you heard at the beginning of my talk. But he had a very neat clinical clue, which was his hair color. This is a picture he took with his iPhone when he was home. We identified that he had short telomeres. We identified a mutation in the TERT gene, and he had gray hair from the age in his late 20s, early 30s. So early graying of the hair, it's not specific, but it's a very good clue to telomere disease. And now I can really look like a smart guy because I walk into a clinic patient's room, you see their gray hair, or you see a relative with gray hair, and you can actually make the diagnosis in the room without actually doing the DNA sequencing. But we do the DNA sequencing. I actually want to mention, and it's a sort of a cute story, but there's a literature and even a minor industry that's founded on the idea that hair dye causes aplastic anemia. Remember I told you there are chemicals, there's benzene. There are lots of law cases about why I got aplastic anemia, blaming it on one chemical or another. And there's an old literature of hair dye causing aplastic. You know, hair dye, it smells bad, it's got all those bad aryl hydrocarbons. It sounds like it should cause aplastic anemia. But now we think differently about this, because when we walk into the room, or when I walk into the room, I ask the patients not only when their hair turned gray, but if their hair isn't gray, do they dye their hair? And that actually usually gets their attention because no doctor's ever asked them that before. It's not been medically important, right? Men and women, it's not just women. And it's not infrequent now to get a history, oh yeah, because my hair turned gray when I was 20, I dyed it because I didn't want to look like an old person. So we don't really think that hair dye causes aplastic anemia. We think that people who were destined to get aplastic anemia were dyeing their hair because their hair turned gray early. So this is a big family. It's almost redundant with what you've heard earlier, but it's a big Mennonite family that lives close to Washington, which, as you've heard already, has many of the manifestations of liver, lung, and marrow problems. This is a huge family. I think it's maybe larger than yours, and there's a lot of interbreeding. It wasn't so easy to actually, consanguinity, I think is the proper term, to to figure out this family tree. One of our Howard Hughes students spent a couple of weeks getting it right. But everybody who's shown in green has a new mutation in the telomerase gene. So this is a very illustrative family. I'll just go through it quickly because I think you've gotten the point already, but it's still a cool story. So the patient is a dairy farmer, came with moderate aplastic anemia that progressed to severe aplastic anemia, not responding to therapy. And we, because his hair was in fact very gray, and he was just a guy in his 20s, made the diagnosis in the clinic, found a mutation, and he actually was successfully transplanted by my colleague Rick Childs from his sister. And it's a really good example of the value of genetic testing because he had 2 matched sisters, one of whom was hematologically normal except her red cells were large, and she turned out to have a mutation as well. And it would have been, we know from experience, a disaster to have used her bone marrow or her stem cells in him. She does not have enough stem cells to support a transplant. So he was successfully transplanted from the sister who was genetically normal. He's doing fine. But that is the point, that in families, even though the mutation is present in multiple members and one person's come to attention as having aplastic anemia or pulmonary fibrosis, you can look at other family members and they can be hematologically normal. They would pass muster in a blood clinic unless you actually looked at their bone marrow, in which case they have very low cellularity, and if you do sophisticated measures of blood cell production, they're abnormal. So this family also showed liver disease, as you heard. It was fatal liver disease in 4 members of the family. One woman actually had a liver transplant when she was 19 for fulminant liver failure, all of whom have the mutation. This is a family that I like to talk about because it's sort of a vindication of the NIH approach to clinical research. This is a family that we reported back in the 1980s in one of the minor journals because we'd seen a relationship between aplastic anemia and liver cirrhosis. No idea what it meant, but we wrote it up. And when we understood telomeres 15 years later, I actually still remember the name of the family, but we couldn't reach them. Nobody answers the phone. The doctors died. The office is closed. So I sort of gave up on being able to go back and make a retrospective diagnosis until I got a call from our blood bank that there was a young woman there who wanted to donate her bone marrow to the National Marrow Donor Program. She wanted to do something altruistic because she had a terrible family history. And she mentioned to our transfusion medicine chief that she had lost her brother and her father to aplastic anemia and that they had been seen by me. And indeed, her brother had come to me with very mild platelet count abnormalities, just a teenager at the time. The father had aplastic anemia. They both ended up having cirrhosis. The father extremely severe. He essentially bled to death from his cirrhosis, and both of them had died of their aplastic anemia. But we looked at her, and she actually had short telomeres. So that was alarming. She has 2 little kids. You know, it's a little upsetting. She has short telomeres, but she has no mutation. So I'll see if anybody's awake. And Jerry, you already know the answer. So why does she have short telomeres? Genetically normal. This is not hard. Where do we get our telomeres from? What are the cells that start us? It's a sperm and an egg that come together, right? So if dad has really, really short telomeres, his sperm is also going to have really short telomeres. So on average, her telomeres are short because she started with half of her chromosomes having very short telomeres. But both in families and also in mouse experiments, that seems to be okay. That as long as you can repair your telomeres, even if they're short, you do all right. So the repair is important. And now we talked about this earlier, if we look actually at patients with cirrhosis without any family history, just at people with cirrhosis from hepatitis or diabetes, diabetic steatosis, viral infections, alcohol, between 5 and 8%. In our series, and we don't even look at cirrhosis patients in general, but we look at cirrhosis patients from University of Arizona, German study that came out at the same time in hepatology, they have mutations in TERT and in TERK. So this is a risk factor. It's actually the only well-defined genetic risk factor for cirrhosis in humans. And then, if you've heard, pulmonary fibrosis is one of the lesions that is most worrisome in patients with TERK and TERT mutations, but they're not always progressive. Some patients show progressive disease. Other patients remain stable throughout their whole life with just CT scan findings. And these are the relationships that have been found by others between TERT and TERK mutations and pulmonary fibrosis. So this is one of the more unusual presentations of a telomere problem. This is telomere shortening problem that occurs in the fetus. So one of our colleagues in the National Cancer Institute had a patient who had a terrible course. The patient was transplanted with an umbilical cord transplant, Very poor engraftment, even though usually umbilical cord blood provides terrific stem cells. The engraftment took 6 months, 9 months before cells came in, and then a year and a half afterwards, the patient developed leukemia in the donor cells. So because, as I'm going to show you, both this poor engraftment and the leukemia suggest a telomere problem, we actually looked at the original umbilical cord blood, both before it was transfused and also when it was in the patient. And what's shown in red is just the marked shortening in telomeres. This is about half the length of a standard umbilical cord. Umbilical cords have wonderful telomeres. You know, just a baby just starting out. Not in this case. No mutation that we could find, but the telomeres are really short, and they almost certainly are responsible for this course, the unfortunate course in this patient. And this is, again, mainly for clinicians, but it just shows you that even in a hematology clinic, there's an enormous variety of blood diseases that we've now associated with telomerase gene mutations. And I don't think this list is finished. This is just selective based on the patients who come to us. And in a substantial proportion of them, even when the telomeres are short, we don't have a mutation just yet. And part of the reason for not being able to make the diagnosis is that we look at the coding sequence. But telomerase, because it's so important, as you've heard, is very tightly regulated. And there are a lot of genes involved. And I'll just show you one example of how sophisticated you have to be to actually find the genetic lesion. So here's a family, again, pulmonary fibrosis, aplastic anemia, lung cancer in this family. Very, very short telomeres in the family members, no mutations. They've got to have a mutation in TERT or TERK, right? Well, they don't, but they have a mutation in the promoter region for the TERK gene. So sequencing upstream, young woman in our lab named Anna Albers on loan from the Netherlands, found actually what turns out to be the first pathogenic mutation in a very important region, a cat box, which binds to many different transcription factors. We could show, I don't show it here, but that this is functionally decreases TERT activity completely. So now looking in just a regulatory sequence, you have an explanation for the problem in this family. And of course, we haven't looked at the other coils of chromatin that are upstream or downstream, things that bind very many other genes that are involved. So I think those explanations will be harder to get at. Everybody at NIH is doing IPS. We are too. And it is actually helpful in patients who don't have a lot of cells to be able to generate induce pluripotent stem cells. And actually, you do get interesting information. So in these experiments of Thomas Winkler in our group, this is telomere regeneration that occurs with inducible pluripotent stem cells. And they do. They upregulate telomerase, and they repair their telomeres. And this is the appearance in the middle. I wonder if I can get it to show. This is what happens in the IPS that are derived from the skin of somebody with a TERT or TERK mutation. And the behavior of these IPS cells seems to follow the behavior of patients. So even when you have a brother-sister pair, one of whom has more severe disease than the other, the telomere repair is better in the person who has the less severe disease. And you also can come up with some other interesting insights. So we think that the stem cells sit actually not in 20% ambient air. They sit in a very hypoxic hematopoietic stem cell niche, and actually telomere repair also is much better when you reduce the oxygen, and that's shown at the bottom. So you can do some neat things to reproduce what we think is happening with stem cells. Okay, so this is what I want to say about telomeres and tissue repair. 3 different organs to date that we can really identify. We think that there has to be an environmental factor, that people rarely will just get cirrhosis on their own, that they usually have to have something that incites it. We think that's true also for the bone marrow failure, that there's an immune overlay because these patients can respond to immunosuppressive therapy, but they tend to relapse. And as I'll show you in a moment, they also probably will tend to go on to other things that are not desirable. And so we think of these as being risk factors for these very common syndromes, as I've shown you, as opposed to determinant genes that cause an obvious clinical syndrome in a young child. Now, coming back to this family, the Mennonite family, the father also was unusual. He was actually a patient north in Baltimore about 15 years ago. The physicians, actually well-known hematologists, took care of him. He had a very unusual course because he presented not with marrow failure but with myelodysplastic syndrome and very rapidly progressed to leukemia. He was a young man at the time and was treated with chemotherapy. And almost invariably, you can get a patient get him through one course of chemotherapy, and you usually get a young person into remission, although it doesn't last very long. But he had a single round of chemotherapy, never recovered his blood counts, and he died. It's really a disaster. As I told you with this other patient, the Army officer as well. So we actually determined that he did in fact have this mutation. And then in a paper that I'm just showing you, the front piece here, we showed that again, if you look at just patients with acute leukemia, no family history, not coming from aplastic anemia, again on the order of 5 to 8% of them in several different series of patients, will have germline mutations in mainly TERT, and almost always have cytogenetic abnormalities, which only occurs in about 50% of patients. So again, this seems to be a risk factor for acute leukemia with chromosome abnormalities. And in our patients with aplastic anemia, I told you that they also can develop leukemia over time, and the telomere length, with or without a mutation, the telomere length is the major determinant of them going on to leukemia. So this is a study that we published a couple of years ago now, looking at several hundred patients who had been treated by our group, only one of whom actually had a mutation that we had identified retrospectively. But those patients who had short telomeres, even if they were in the normal range, those patients with the shorter telomeres, probably just because their bone marrows had to continually replicate and they really had exhausted their stem cell pool, those are the patients as shown in green who had about a 5 to 6-fold higher rate of going on to the secondary MDS or AML. So this is actually useful in terms of helping predict whether patients need to go to transplant or get other therapies earlier. And we can actually see what's going on in the bone marrow of these patients because, again, at the NIH, if you work in a clinical laboratory, somebody's stuffing that frozen bone marrow, those frozen cells, in a freezer, and they're available years later to actually do experiments on it. So if you go back now to these patients with normal or short but in the normal range telomeres, and you take them out, you can actually see those short telomeres. So telomeres, when you do histochemistry, fluorescent in situ hybridization, you can see the telomeres at the ends of the chromosomes. Every chromosome looks like a kind of double-headed worm, and little green lights at the end. Those are the telomeres. Patients who have short telomeres, you don't see that in every chromosome. And it's when you don't see that fluorescent signal at the end that tells you that that's critically short telomere, and that's telomere attrition that's going to lead to chromosome instability, which you can actually demonstrate in these bone marrows years before the patients ever go on to AML. So if you do spectrokaryotyping, as we've done actually in this building with Tom Reed, you can see the non-reciprocal translocations, aneuploidy, Robinsonian translocations that are typical in animals with telomere, with induced telomere problems, and in cell lines and so on. You see these in these patients. And now we have a very sophisticated way of actually looking at single telomeres. This is just an example of what we think is going on as patients evolve from marrow failure to leukemia. We can actually look at a single chromosome with an assay that's called single telomere length analysis. So this is looking at the X chromosome, and it's really an adaptation of the Southern blot technique. You're basically using a telomere probe, that's one end, and at the other end is a subtelomeric specific sequence, that's the other oligonucleotide, that allows you to amplify specifically for an X or chromosome 17 or whatever. This is X chromosome. So shown on the left is a patient who's stable, bone marrow failure's fine, they got better, and you see their fragments that you get, but they're all about the same length over this 3-year period. Here's the patient who's evolved to chromosome 7 loss. I told you that's what typically happens. And you see the telomeres on average are getting shorter, and you also see these very short telomere fragments that are present in this patient at the time that they're about to develop a chromosome abnormality. And you can now see the shift, which is shown in multiple patients below, to much smaller chromosomes, much lower median length, and more important, smaller telomere fragments in those patients who go on to myelodysplasia or leukemia. So this is the summary of the cancer part of the story. Obviously, it's easiest when you've got a genetic lesion to study this and to see cancer frequency. That's the purpose of these NCI studies. But the telomere shortening occurs also physiologically, or in some instances, iatrogenically. We treat patients for cancer, and then we've got this terrible problem. There's the famous news reporter in New York, who everybody's heard, that secondary MDS, having been treated for breast cancer many years earlier. So we give all these cytotoxic drugs. The bone marrow's got to work really hard for months and months and months. That's going to lead to telomere shortening. That doesn't have anything to do with mutations. It just has to do with the stress that we put on the bone marrow. But this, we think, puts patients at risk for secondary MDS, where there's always very marked chromosome abnormalities. It's a characteristic of secondary MDS. And as I mentioned to you, the bad news is that we also get telomere shortenings just sitting around, just as we get older, and that's the major risk factor for cancer almost invariably. And I've shown you our work, but there are also other examples. I'll just show you 2 other approaches that have been used at sort of the spectrum. One is that, in Iceland, 1/2 of the country studies the other half of the country. That's shown in the author list here. So when you do SNPs, there are sites that are in the telomerase gene and the TERT gene that come up and give a 5 to 10% higher rate of a wide variety of cancers. And there are tons of GWASs that have been done in multiple diseases that pinpoint the telomerase gene, the TERT gene. On the other side is this very elegant study that was done in the north of Italy. It came out just about the same time as Phil Scheinberg's paper in JAMA. So here's a cohort of about 1,000 people who are being studied in the north of Italy, in the Dolomites. And they're in a cancer study. And so they track who gets cancer and who doesn't, and then go back and can get the leukocytes out of the freezer and look at who's got long telomeres and short telomeres. So very similar to what I showed you for our aplastic anemia patients, those patients who had telomeres in the normal range, but in the shortest third of the normal range, have a much higher rate of cancer and a much higher rate of cancer mortality. Now that may reflect genetics, it may reflect how much reactive oxygen species they've seen, it may reflect their repair capacity, we don't know, but this sort of association between telomere length and malignant outcome has been shown in other studies. This is the most elegant. Okay, so this is what I want to say about cancer. The patients who have dyskeratosis congenita, the kids, 1,000-fold higher rate of cancer of the mouth, 100-fold higher rate of leukemia. I showed you the GWASs and the genetic studies suggesting a few percentage higher rate with SNPs that we don't know exactly how they function. But for me, the most interesting group is, of course, the aplastic anemia patients, but other patients who have inflammatory diseases in which there's this demand for tissue regeneration, which puts individual cells at risk because they're going to get inevitably telomere shortening. Now, how that works in the liver and how that works in the lung is not entirely clear, but the assumption is that, for example, in the liver, you've got liver regeneration, you get telomere shortening, and by just bad luck alone, you start to get chromosome rearrangements and signals for fibrosis and ultimately cancer. And there are a lot of examples of this. This has been a holy grail in malignancy since the early part of the 20th century. Why does inflammation seem to precede cancer? And I think that telomeres are the likely explanation for this. And I wish I could say that I invented this, but again, there is always somebody smarter who lived 100 years earlier. And this is a wonderful book that was written by this very unfortunate guy named Theo Bovary, a German actually, despite his name, who published this book at just the wrong time. He did these wonderful studies, really implicated chromosomes in causing cancer. Unfortunately, the book was published just at the beginning of the First World War, so totally ignored, and he died a short time after the war was over, unfortunately. A really sad story. But he like Olovnikov, very wise statements that are made in this book. Okay, I'm going to finish by giving what may be a little bit of good news. So everything sounds terrible. Our telomeres are getting shorter. We've got diseases that affect families like the one you heard about, which are just terrible. I mean, I feel even bad just talking about this because it's always upsetting when you've got a patient in the room and you're talking about things that don't always have a good outcome. But that's the reality. So we've got all this bad news, and of course, as I told you, even we, the doctors, our telomeres are getting shorter too. So is there anything that we might be able to do about this? And the answer is that maybe yes. So this is a photo that I took of one of our Mennonite patients, and she had aplastic anemia back in the 1990s, and she'd been treated with a very old-fashioned medication, which she's showing the result of, which is that her hematocrit went from being transfusion dependent to being normal. And she got male hormones. And we've used those in hematology since the 1960s. Not really knowing why they work, but they work. Just as we've used steroids forever and ever, not knowing why they work, but they work. So they do work in a few patients with aplastic. Every hematologist got at least one patient he's treated with marrow failure, usually a young person, usually with moderate aplastic anemia who gets better with a male hormone. And this is one of those few treatments. You know, the athletes really didn't complain about getting the male hormones. It's made it harder for us to get them. You can actually tell patients you're probably going to feel better, even younger, when you're on this treatment. You're not going to have much in the way of side effects. They really are very well tolerated. But how do they work? Well, actually, we never knew, but I think we do know now, because male hormones, but also female sex hormones, directly regulate the telomerase gene. Now, that's not new to us. We've just shown that happens in the bone marrow and it happens in lymphocytes. But in cancer cells, that was demonstrated. People interested in prostate and breast cancer, telomerase regulation. And this is work of my colleague Rodrigo Collado in our lab. So synthetic and natural male hormones will upregulate the telomerase gene. And that's likely the mechanism by which they help repair the bone marrow. I think I've got a... You can see that actually in animal models. So if you take animals and take mice that are deficient in telomerase and you stress them, you give them a bone marrow you use their cells for bone marrow transplant, as shown here, when you give androgens, you actually can rescue the telomeres. This is an animal that has no telomerase activity, it doesn't work. This is an animal that has some telomerase activity, it works. Here are animals that are getting repeated doses of irradiation, and especially in the older animals, you see you're actually able to preserve the telomeres in these animals that are their bone marrows are being stressed by the x-rays. So this is the last slide I wanted to show, which is that we actually have an ongoing protocol that we alluded to of danazol, which is a synthetic male hormone, very little in the way of toxicity in patients with pulmonary fibrosis and with bone marrow problems, to see if we can improve them in terms of their clinical status, but also whether we can do anything with their telomeres. And the amazing thing here is that if you select your patients based on what you think is the physiology, not just everybody with aplastic anemia, but people with short telomeres, almost everybody responds. So these are by protocol criteria. Platelet counts go up 20 or 30,000. Hemoglobins go up by a gram or two. So everybody responds, and it looks also like the telomeres either are stable or elongate. So that would be consistent with the hypothesis that we're actually directly impacting on telomerase. But we'll find that out when we finish this. This is a 2-year study, and we've got more patients to look at. But we're not seeing the accelerated telomere attrition you expect in these patients with TERT and TERK deficiencies. That's everything I wanted to say. These are just a few of the people who actually do all the work. I'm just the spokesperson, but there's obviously a huge amount of labor that goes into these clinical and laboratory studies, and these are the people who really deserve the credit. So I think there's time for a few questions. Yes.
Please ask your question into the microphone. There are a lot of people listening.
I'll repeat the question if it's...
There is a brief summary in the current Nature Medicine attempts by a number of pharmaceutical companies to develop inhibitors of telomerase to decrease telomere length to treat various cancers. And there's reports of several studies that have stopped and others that are now ongoing. I mean, what is your reaction to the idea of...
Yeah, so I mean, that's why it was actually difficult to publish the leukemia work, because the paradigm has been, and it's true, that most cancers, in order to survive all those replications, have to upregulate telomerase. And they don't actually always upregulate what I've talked about. There are other ways that you can actually repair the telomere, something, for example, called the alternative pathway of telomere repair, which depends on recombination at the telomere end. It doesn't actually have an enzyme involved. The longer telomere will contribute to the shorter telomere during the course of mitosis. So that's the alternative pathway, which is on, we think, only in cancer cells. We don't know what its normal role is. So that's been the target. And the assumption has been that this upregulation of telomerase is a requirement for cells to be malignant. It's very common across a lot of cancers. But that's an acquired, not an inherited feature of those cells. And it's been a reasonable target, but as far as I know, totally unsuccessful in the clinic. Partly because the cell, I think, I actually think, this is my own speculation, but because we think we're looking at early events in cancer, in oncogenesis, when we look at aplastic anemia. I hope that I made that point, maybe I'll make it explicitly. You know, people who do genomics, like my old friend Tim Lay and others, are looking at cancer. You know, they're looking at really cancer cells that are well established. So you can find lots of mutations in those cells because it's a big world out there of those cancers. So they've got plenty of opportunities to replicate. They're mitosing like crazy. Lots of mutations can occur. We're looking at the very earliest events, and we don't see those mutations occurring. What we're seeing instead is telomere shortening. And I think that another inference from telomere shortening and from all this work going all the way back to the early 20th century is that getting past those short telomeres has got to be one of the earliest things that a cell has to figure out to do if it's going to be a cancer cell. It's got to figure out how to keep either the cell alive with very short telomeres, or better yet, to repair the telomeres. So I think that it's a very early and very strong event that rescues the cells, and how easily that's going to be inhibited by an antibody or by a chemical is, that's the question, because it's not a late occurrence.
Question? What do you think is the role of reactive oxygen in terms of...
So there's a whole different area of telomere biology, because there's a lot of tissue culture data that suggests that if you expose cells to damage everything, DNA gets damaged by reactive oxygen species, including telomeres. So you can reduce telomere length quicker with reactive oxygen species. And as I showed you with the IPS, if you reduce the amount of ambient oxygen, you actually improve telomere repair, even in patients who are deficient in that. So I think that in that Brunico study, that's probably what we're looking at is reactive oxygen species and their effects. And there's also large literature that's harder to interpret that relates telomere length, for example, to cardiac events. So lots of different studies that have suggested that people who have short telomeres, in their 40s or 50s, are at higher risk for a variety of early sudden death, atherosclerosis, atherosclerotic plaques, lots of different papers published, usually severely underpowered to show what they want to show, but still the suggestion. And we don't think that that's genetic. We think that that presumably is a reflection of what's occurring in general. And even to make it's obvious, but if we're worried about things like esophageal cancer or cancers in general, as in the Brunico study, white cells have nothing to do with that, right? They're just a marker of telomere length. We're not measuring the telomeres in the bowel or the telomeres in any organ that's actually getting the cancer. We're just looking at the telomeres of white cells, which are not related to the cancer. I think it just reflects this general process. That's the thinking.
So is there a, here, make it loud out.
If I read your last slides correctly, estradiol increased telomerase.
Right. That's the, yeah.
Androgens, have estrogens been effective in aplastic anemia, or if not, right about the mechanism?
Yeah. So the way it works is through estradiol. The androgens are aromatized, and there are estrogen response elements in the promoter, and that's the mechanism. Estrogens actually are much less well tolerated than our androgens, so they've been really very infrequently used. We actually tried them kind of off-label in a patient for a variety of reasons, and she got sicker before she could get better. So they're not well tolerated. But it leads to a larger question, which is the role of estrogen replacement, for example, in postmenopausal women. And there is actually a single study which we tried to reproduce but weren't able to get the right samples. There's a study from Korea that suggested that women who were receiving estrogen replacement postmenopausally had, on average, longer telomeres than women who were not. We're trying to do similar studies, for example, with men who have prostate cancer and either chemically or surgically castrated. And those are early days, but it looks like men who have an absence of testosterone have more rapid telomere attrition even over a 6-month period. But it's easy to, this is really very speculative because these are small differences and they require very large sample sizes, and it's just really hard to get hundreds and hundreds of well characterized samples, especially from normal individuals or people who have very severe diseases in which who cares about telomeres? You want to get rid of the prostate cancer. So I think it's going to require much better engineered studies.
So why do you think TPO mimic worked in the presence of so much endogenous TPO?
So that's a good question. I actually do have a lovely slide floating around somewhere, but let me give you the picture. I'll give you the word picture of what I think is the difference. So you've got a normal bone marrow. We actually do know that stem cells have receptors for thrombopoietin. In fact, patients who are genetically deficient in the TPO axis do have a stem cell defect. It's just that the platelets are most obvious. So in retrospect, there's plenty of reason to think that TPO should work on the stem cell. So that biology is fine. So why is TPO, despite the high levels of TPO, why does this mimetic work? I think there are several reasons. The first is that under normal circumstances, thrombopoietin is a big protein. So it's got all the issues of protein metabolism. It's binding to albumin. It's binding to other things we don't even know about. It's binding to other cells. And by the time a TPO molecule has got the opportunity to get in to one of those hundreds or thousands of stem cells that sit in a normal bone marrow and trigger it to replicate, it doesn't have much of a chance. Now contrast that with the circumstances in aplastic anemia. So I don't know whether TPO would work or not, but we're not actually working with TPO. We're working with a little chemical. And I think that we don't have any of those issues of protein binding. We don't have issues of binding to other cells because they aren't any. The only cells that are left are those few scattered stem cells sitting in their niches, and I think we can flood those niches with many orders of magnitude higher concentration. I don't know that, but I'm guessing that that's what we're really doing. Jerry.
But it stimulates
what's so funny is that when you treat patients with L-Trombopag who have ITP, they don't get high red cell
No, you
counts.
don't. But I think it's because, you know, I think it's being bound up in the megakaryocytes. I mean, I think that's what's being stimulated under those circumstances. So the megakaryocyte is sopping up the L-Trombopag, and it doesn't have a lot of opportunity. That's my hypothesis, and it's just not getting into all those, or if it is getting into those thousands of stem cells, it's triggering one here, one there, and you may not be able to get the few stem cells that are left really with multiple molecules that are binding to them. I mean, you're right, you don't see those effects.
So how do you think fibrosis is activated by telomeres?
Yeah, I don't know. I mean, it's, you know, it's really just been basically unstudied, and as we talked about, there are obviously experiments to be done, but the assumption is that the default pathway, I mean, let me guess, you know, that a cell that's got critically short telomeres signals for some sort of response locally. That could be a fibroblast growth factor of any type, and you end up with cirrhosis as the surrounding effect, but nobody knows. It seems that it shouldn't be hard to study, and that's why we would do those liver regeneration experiments.
So is there a relationship between long-lived species and telomere length?
No. And actually, you know, I'll make a comment about, I mean, I actually think that the aging stuff is really very unconvincing. And I think it's true and unrelated. Hayflick phenomenon, no question. But, you know, as we age, we get shorter telomeres, but a lot of other things happen as we age as well. And I don't think that telomeres are a particularly satisfactory explanation for aging. I think actually a lot of the stuff that's written by some of the important people that we've mentioned is really bogus. I mean, aplastic anemia, well, you know, aplastic anemia is not a consequence of aging. Neither is liver cirrhosis. Neither is pulmonary fibrosis. These are not, you know, we don't all normally develop these things as we get older. So I think that there's kind of an industry, and I mean a real industry, that's promoted telomere lengthening or telomere. I mean, there are news reports about whether you exercise, you can get your telomeres longer. I just think it's made up, and I think it's really hard to deconvolute all the factors, and the fact that as we age we get shorter telomeres doesn't mean that telomeres are making shorter. You know, one of the people in the National Institute of Aging, after the last talk I gave, and they sent me a really nice correlation between testosterone levels and telomere length, which is, you know, actually turns out to be, you know, the aging cohorts is pretty good. Individuals, men and women, who have higher total testosterone or bioavailable testosterone have longer telomeres. But that effect, as expected, goes away with age, because, you know, unfortunately those levels fall as we get older. So is that just a correlation, or is that in fact the mechanism by which the telomeres are getting shorter? So it's really hard to know that. And you know, mice, I know the hour is late, but, you know, laboratory mice have very long telomeres. They'd only be 90 years old. You know, their telomeres are 5 to 10 times longer than human telomeres, but they still get old and die, right?
Some of the patients that you mentioned are treated initially, but then go on to develop leukemias, and also in some patients with telomere mutations, they present with other types of cancers, not blood cancers. Mm-hmm. So given that certain chemotherapy agents are purine analogs or adenosine deaminase inhibitors, would those have an antagonistic effect in this patient cohort?
Yeah, that's a really interesting question. You know, I think the prediction would be yes, but I don't know the answer. And, you know, I've always made the assumption that what's really occurring is that they just have too few stem cells to start with. So the reason that we see, you know, this chemotherapy effect in an occasional patient is they quantitatively and qualitatively, they have too few cells and the cells can't repair easily. So they go through a round of regeneration, for example, but they can't repair their telomeres. But is there something really more specific about the individual chemotherapy? That's an interesting idea, and I don't know the answer. And actually, it's addressed. You could address it in animal experiments or even in tissue culture.
Your patients with aplastic anemia who don't do well. Mm-hmm. Do they have a different, I mean, are they different in terms of telomere length or?
Yeah, so the JAMA paper really...
Not just the MDS ones.
Yeah, no, for example, relapse is twice as frequent in patients who have the shorter, are in the shortest quartile of telomeres, as well as evolution. So that would again go with this idea that both quantitatively and qualitatively, not because of a mutation, but just presumably because they've got a reduced stem cell pool. That's the major correlate with outcome. You know, we don't have, except for really, really low blood counts. I mean, I think it all comes back to the number of stem cells that are left after whatever attacks the bone marrow. So patients who have better reticulocyte counts at the outset, who have better counts in the first 3-month period, younger people versus older people, people who have complete responses versus partial responses, all of them do better, as do patients who have the longer telomeres. And I think that's all a reflection of the amount of number of stem cells and their ability to repair.
So could you use that as a prognostic or an identifying feature to say, okay, this patient should go to transplant?
No, I don't, and I'll tell you why. Because I think somebody has to replicate it. Somebody has to replicate that study. So I would not send a patient, with the exception perhaps of somebody with a well-documented TERT or TERK mutation, I would not do anything different than what I'm doing now. Because I think we really need to make sure that this is right. And you don't do that unless you've got a separate replication. You would agree?
Do these patients with aplastic anemia have bone abnormalities?
Yeah, it's an interesting question. I don't think so.
Are MSCs affected? Did anybody look at MSC?
Yeah, no, it's an interesting question, and there's a whole, there are new hypotheses now about how stroma might be able to induce marrow failure. I mean, I don't find it particularly convincing, but it's really hard to study. I think the people who are doing this based on very complicated mouse experiments, how they're ever going to actually show that could occur in humans is really beyond me at this point.
There's a lot of fat there.
There's a lot of fat, and I don't know what the fat is doing there, but,
Well, it probably comes from MSCs.
Comes? Yeah, no, I know it comes from MSCs, but I don't know why that's the pathway that's followed. And whether, there's a paper published, which you probably know, that suggested that fat was a negative regulator of hematopoiesis, but that turns out to be wrong, even if it was published in Nature. But we can have that as an offline discussion. It's late. We tried to reproduce, it's not reproducible. Okay, well, thank you. You've been really attentive for a long period of time.